Well, hello, welcome. We're going to begin shortly, and we appreciate you joining us for this session of Sign Out with the Professor. I'm Louis Hassel, and our program is brought to you as a service to those of you in areas without a number of the digital slide resources that we have, and we hope that it will be of use to you to be able to review the cases that we're going to cover today. We have a number of soft tissue and bone cases that I'd like to share with you. And so let's begin with this first case, which is one that we've done a video on recently, but I'll just talk about it a bit more briefly. This is a 25-year-old woman who has some knee pain, and on radiographic appearance is found to have a lytic lesion in the bone. And if you want to see the x-rays, of course, you can look at the video in more detail, but it was a lytic lesion that had a peripheral area of sclerosis. And so as we look at this at low power, it looks quite cellular, moderately pinkish blue color. And as we look in a few areas over here, I think you can recognize that there is what appears to be pink osteoid being formed here, or maybe collagenous tissue around the periphery of this. So it certainly raises concern for an osteoblastic type of lesion, as you might expect with osteosarcomas or osteoblastoma. But in contrast to osteoblastoma, this is not the sort of hypervascular new bone formation. This is sort of more of a parallel reactive kind of appearance. We can see some other areas over here, I believe in this fragment, where we've got more mature type fragments of bone, along with this very cellular stromal tissue. So here we see sort of a gradation into this bony tissue here and a paucicellular cuff here with kind of a reactive bone appearance. Now, as we look into the lacunae in these osteoid areas, the bone is not particularly atypical. These cells are a little bit on the hyperchromatic side, but not something beyond the realm of possibility for benign tissue. So let's look back at the other areas, the more cellular areas again, and just get an idea of what's going on here in these very cellular areas. So as we can see, there's quite a number of giant cells scattered around, some of them floating loose in and around the tissue, some of them associated with the cells of the tumor. And by and large, these cells, both within the giant cells and the stroma, are relatively uniform. So we can look around at some other areas and see that here's the bone. These cells look like fairly bland osteocytes. So in this situation, if you just have the histology, it might be a little bit difficult because you do need the radiograph to be able to discern that that ossification is at the periphery and that it's in a reactive type of form. And it's not coming out of the entire bone lesion. We do have all of these giant cells, and as we discussed in the other case presentation, these nuclei are all quite bland, and the stromal cell nuclei are similar to those of the tumor. We'll look at here a little higher magnification, and you can see these stromal cells, occasional histiocytes, foamy cells admixed in here. All point towards a giant cell tumor of bone. The patella is a somewhat unusual site for a giant cell tumor of bone, but certainly well described, and a percentage of cases can occur there. So the differential that I want to emphasize here is with osteoblastoma, which could also have some bone formation, and reactive bone due to expanding giant cell tumor in this case. So very quickly on to the next case that I'd like to present is a soft tissue lesion occurring in a early 30s age woman around the shoulder girdle. And here we see a rather blue tumor with geographic pink areas, sort of a map-like appearance. and some other more eosinophilic tissues here with maybe a bit of a vasculature type of background. So here, as we come into high power, we see this is just early necrosis, whereas what we were seeing over here was later necrosis. And we can appreciate at this magnification that this lesion has a fair degree of pleomorphism, along with a degree of lobulation. This lobulation might suggest the possibility of a sheet-like growth of an epithelial tumor. However, as we come into higher magnification, I believe you can recognize that these cells show a lot of vacuolization, along with this pronounced nuclear pleomorphism. And in fact, as we look at this more closely, I think you could define several of these cells as being lipoblastic, having nice nuclear indentations from the lipid globules within the cytoplasm, forming thus very nice diagnostic lipoblasts. This cell, I think, has some indentation here you see from one of these bubbles, and others of these cells certainly show high-grade malignant features. Now, it does look also like we have sort of defined almost epithelioid type cytoplasmic margins and a little bit of packeting. So concern for other neoplasms with sort of foamy cytoplasm might come into play, sebaceous carcinomas and so forth. But this is fairly characteristic with these diagnostic lipoblasts of a pleomorphic liposarcoma. And this being a more epithelioid type of variant of that disorder. So finding diagnostic lipoblasts, demonstrating them by that indentation characteristic into the nucleus that we've illustrated here, and which you can see as you study these slides in greater detail, is pretty much the diagnostic finding for this tumor. These are very pleomorphic tumors, and that is an indication of a great degree of cytogenetic complexity and molecular diversity in terms of the various mutations that accrue and present and drive this neoplasm. Oftentimes, you don't get this much lipoblastic differentiation. You may only have a smaller percentage of lipoblastic differentiation. You can see eosinophilic cells, granular cytoplasm in this tumor. And so just because you have a solid neoplasm, you shouldn't totally rule out the possibility of pleomorphic liposarcoma if you've got the nuclear pleomorphism, because the diagnostic lipoblasts may be relatively sparse, particularly in these more epithelioid variants. You only need about 5 to 10% of the tumor to be characteristic lipoblastic differentiation to call it a pleomorphic liposarcoma. These tumors tend to occur around the limb girdles, and they can occur at a wide array of age ranges, and they tend to be bulky, and as this case was, somewhat of a challenge for resection. So I'll go on here a little bit further, and we'll talk about another tumor that comes into the differential in soft tissue tumors. This is a tumor that also might be called pleomorphic liposarcoma. And I present it to show you a little bit more of the diversity of morphology. So as you can see here, this case has some degree of nuclear pleomorphism. You can see variable nuclear sizes even here at intermediate magnification. And there's a lot of clearing to the cytoplasm, which is, as we come into higher magnification, characteristic of this almost exclusively lipoblastic appearance in this tumor. So here we see many vacuoles indenting and pushing aside the nuclei, forming this nice signet ring cell appearance in some areas, and others with sort of dual bipodal modal lipid droplets and an indented nucleus, sort of like an old fan belt from your car, and various other morphologies in this lesion. So here, a very typical lipoblastic type of pleomorphic liposarcoma. There are several other morphologic patterns and variations on this tumor, which, though rare, seems to have no difficulty in finding a variety of ways to express itself and create interesting morphologic patterns. Okay, well, I don't see any questions yet on this situation, so let's go on to the next case. This is a case, obviously, of another soft tissue tumor, somewhat lobulated, and as you can see, it has some dense fascia involvement here, lobulated, pink, maybe some inflammatory or cellular areas here. So as we come into higher magnification with this tumor, let's take a look and see what we have. So looking at low magnification, we see that this is a spindle cell tumor. It's got a little bit of a herringbone pattern, a little bit of fasciculation, if you will. But note that it has a little bit of a blue tinge to the cytoplasm. And in contrast to the pleomorphic tumors that we just looked at, this tumor is very monotonous. It's extraordinarily uniform in terms of the very small, bland nuclei here, a lot of fibrillar collagenous material, as well as this intervening slightly myxoid ground substance around this. We don't see anything definitive in terms of vascular pattern, a few variable vessels, maybe some extravasated red cells. And our location here, fairly typical, is associated with some of the deep fascia and fibrotendinous tissue. As you can see here, we have some dense fibrotendinous tissue and a little bit of an infiltrative pattern to this lesion. Now, this is an important lesion to identify on biopsy because this is no longer, in most cases, considered a surgical disease, as it can be managed quite adequately conservatively and using potentially targeted therapy for some of the specific molecular drivers in this tumor. So the thing that helps us to define and differentiate this low-grade spindle cell lesion from other tumors, such as low-grade fibromyxoid sarcoma or other spindle cell tumors like solitary fibrous tumor and so forth, is the presence of a CTNNB1 mutation, or in other words, a beta-catenin expressing tumor. So one of the problems with that stain, of course, is that it's not always every cell, and that it's not always every case that will express the immunohistochemical marker. Additionally, the stain is somewhat difficult to interpret because, as I've indicated, not all the cells will be positive. So here's an example of a stain from a biopsy, and at low magnification, it looks pretty negative. However, as you come into higher magnification, you see that there are some cells here that are expressing this marker in the nucleus. And that's where we're looking for the expression. So we're looking for a nuclear expression of beta-catenin in this tumor. Now, in our hands, this marker is probably positive about 75% of the time in these tumors. And so what are we doing with the rest of these tumors? Or what are we doing with a case like this where you think it's probably positive, but maybe you're not quite totally sure? Well, in this circumstance, there is a molecular test, of course, that can be done to demonstrate that mutation. And we have used that fairly liberally to help overcome the diagnostic challenges with a beta-catenin stain, as you can see from this slide here, which is a challenge to interpret, I will grant that. But I want to emphasize the importance of making this diagnosis on the small biopsies. So this is from a needle biopsy sample. As you can see, low cellularity, spindle cell proliferation. We don't want you to sign this out as just low-grade spindle cell neoplasm and assume that that will mean that it gets a conservative excision. If the differential includes a fibromatosis or desmoid tumor, you should strive to make that diagnosis as a specific diagnosis. Well, one of the things that's in the differential considerations for this tumor is this tumor, or for fibromatosis is this tumor, which, as you can see, again, has maybe a vaguely lobulated appearance, mostly pink, not very cellular. As you see, as we come into higher magnification, a few scattered inflammatory cells or cellular areas, a little bit more cellular than the fibromatosis that we just looked at, but a fairly bland appearing tumor, not a pleomorphic tumor, very low-grade nuclei, as you can see here. And sort of a fibrosing, streaming pattern of nuclei and fibrous tissue. A little bit of myxoid change in the stroma, which can be variable over the various areas of the tumor, a little bit more up here, less down here. Sometimes a vaguely lobulated or even nested lobulated appearance to this tumor. Again, the differential for this is a number of other low-grade spindle cell tumors, but particularly this is an example of a low-grade fibromyxoid sarcoma. Now, I want to emphasize that this is a low-grade tumor. As you can see, it's not a pleomorphic tumor. These tumors are often MUC4 positive, and they also have a characteristic fusion gene with the FUS CREB-BL2 gene. So that can be demonstrated by FISH to more firmly establish that this is a translocation type of sarcoma and not a fibromatosis. So if you need to do molecular analysis to differentiate, whether you have a CTNN1B or a FUS-CREB mutation fusion, whatever, then that should be done because the management of these two tumors would be quite different. We'll take another example of this tumor. Here you can see, again, slightly nodular example, a little bit of myxoid tissue. And as we come into high magnification, I think this is actually just another section from the same tumor. You can again see this quite low-grade appearance. And, a few linear, slightly branching vessels, loose myxoid tissue, low-grade spindle cell appearance. You'd have a hard time finding mitoses in this tumor. It's certainly a grade 1 tumor. And usually can be managed with local excision. Recurrences do occur. This is most frequent in the sort of early adulthood to early middle age category. So that sort of places the summary here on low-grade fibromyxoid sarcoma. And we'll go on to the next case, which for some people can be a point of confusion. Now I'll turn it backside right so that you can see the skin at the top. So as you can see, this is a subcutaneous tumor. It's lobulated, it's quite cellular, and it's looks like it may have some myxoid changes to it. So for many new or people who are beginning in soft tissue pathology, the two terms that can be somewhat confusing are low-grade fibromyxoid sarcoma and myxoid fibrosarcoma. A lot of similar suffixes there in the wording. So you can see from this tumor that it is very myxoid, but you can also see that this is very high grade. It's got a lot of pleomorphism to it. It's got a lot of nuclear variability. It's got all this myxoid change. And it's here, it's got some solid areas like this. It's certainly infiltrating into the fat. So this is a tumor that previously might have been called Myxoid MFH, now has been retermed fibromyxoid sarcoma. And it's to emphasize that this is a high-grade sarcoma, in contrast to low-grade fibromyxoid sarcoma, which is obviously a very low-grade sarcoma. The genetics on this sort of a case would be highly complex, very protean in terms of the manifestations. This tumor also has sometimes has what's been called curvilinear vessels. I'm not sure that we see those really well here in this fatty tumor, but this is it's infiltrating in the fat. So how would you differentiate this from a myxoid liposarcoma? Well, again, with myxoid liposarcoma, that is a translocation sarcoma. And just as a clue, translocation sarcomas are hardly ever, if ever, this pleomorphic. They're usually quite monotonous. They're quite uniform, one cell, one area to the next. And they don't have this high-grade cytology that we're seeing here with bizarre cells, streaming high-grade nuclei, high mitotic rates, and so forth. So Myxofibrosarcoma should not ever really be in the differential with low-grade fibromyxoid sarcoma, even though the names sound very similar. So let's move on again to another low-grade tumor, here one in the fat. And we've, I think, done some videos on this type of a lesion before, that a tumor like this might be a lipoma, might be a variant lipoma, or might be a well-differentiated liposarcoma / atypical lipomatous tumor, depending on, of course, the location and presentation and so forth. So the diagnosis of well-differentiated liposarcoma / atypical lipomatous tumor does not depend upon demonstrating lipoblasts, but is quite easily based on the finding of scattered atypical stromal cells within the fibrous matrix, within the fibrous bands between lobulated fatty tissue and sometimes out in the fat. So here we can see a few of these type of cells. Here's one out within the fat. Here are several within the band of fibrous tissue. So these kinds of fields in and of themselves at a single view would justify the morphologic diagnosis of well-differentiated liposarcoma or atypical lipomatous tumor. Now, I've done a recent series or a video on this talking about the differential based on location. And there is justification for using those two terms based on location, because the behavior is quite different based on the location being either retroperitoneal, periscrotal, or soft tissue of an extremity. The latter being by far the more indolent and well-behaved. Dedifferentiation can occasionally occur in either one of these because they share the MDM2 mutation that is characteristic of these tumors. So just to give you an idea of this morphology, sometimes these atypical cells can be plentiful. Sometimes they're really quite rare and may require a pretty extensive search, because obviously in the retroperitoneum especially, a lot of benign fatty tissue can be resected along with the more diagnostic tissue. Now, MDM2 immunohistochemistry has been applied in some circumstances and can be useful, but is not entirely sensitive nor necessarily as specific. And we'll talk about that a little bit later when we talk about dedifferentiation. Now here's another tumor that comes into the differentiation, or excuse me, into the differential sometimes when you have a myxoid tumor. As you can see, this is a variable cellularity tumor, some more cellular blue areas, broad zones of quite myxoid appearing tissue. And as you can see here, there is this very nice, delicate vasculature along with this tissue. So this would pretty well exclude the diagnosis of intramuscular or soft tissue myxoma because they do not have this characteristic vasculature with the delicate vessels running in between things and occasional arcades and so forth. So they also will generally not be quite this cellular. Now notice here we have a few areas of fat. You might occasionally find what could be considered lipoblasts in this tumor, and that should alert you to the possibility of a myxoid liposarcoma. But in general, those are not required for the diagnosis. The myxoid change, the vascular pattern, and I would say the characteristic mutation would be the thing that you're looking for in this situation. Now, like low-grade fibromyxoid sarcoma, this tumor has a FUS translocation partner. So it's a T1216, whereas the low-grade fibromyxoid sarcoma was a T716. It's the FUS gene on chromosome 16 that we're pairing with. And that is entirely diagnostic of a myxoid or round cell liposarcoma. The vasculature is quite characteristic, as I've mentioned, and can steer you certainly to the diagnosis. What do we do with the more cellular areas? And we'll take a look at this on this slide here. As we come into focus. Oh, there we go. Now I see. As you see, we do have some very cellular areas. No fatty differentiation identifiable at low magnification or intermediate magnification here. And even as we come to higher magnification, these cells are relatively monotonous. They're kind of small blue cells, scant cytoplasm, very dark hyperchromatic nuclei. These are the round cell component and what led to the name round cell sarcoma. But as you can see in this case, there oftentimes is a great deal of overlap, variable amounts of myxoid versus the round cell component. And in general, cutoffs, percentages of round cells may have some prognostic value, but are not critical in the differential. And so myxoid or / round cell liposarcoma is an entirely appropriate designation. The difficulty becomes when there's a high percentage of round cells and you have to differentiate this tumor from other small round blue cell tumors. Things like Ewing sarcoma or the Chick-Duck's sarcomas and some of the B-core sarcomas can have considerable amounts of round blue cell components, as of course might rhabdomyosarcomas and other tumors in that small blue cell category. And so this again points up the value and importance of the FISH testing for these translocations to be able to ferret out the specific diagnosis. But I did want you to have a good feel for the morphology here. I'm not a molecular pathologist. I'm not a FISH testing person per se, but I do think that we can see a lot and get a long ways if we know the proper morphology and are recognizing the vasculature, the myxoid and round cell features that can help to steer us towards the diagnosis of myxoid or round cell liposarcoma. So let's go on to the next case. This is a case that recently crossed our desk, and we're shifting out of the fatty tumors per se, although looking at this tumor, you can see that it is intimately associated with the fatty tissues here. Obviously a subcutaneous or a cutaneous tumor involving the dermis, sparing the epidermis, and infiltrating into the deeper tissues. So this tumor has a little bit of sort of myxoid appearance to it. The vessels are not particularly prominent. And we note here that the tumor infiltrates around, but seems to spare the adnexal structures. That's a very important point, as oftentimes metastases will tend to displace these lesions. So this is a primary cutaneous tumor. And the other feature that I'd call to your attention is this pattern of infiltrating the fat and extending itself around the adipocytes and gradually engulfing and essentially overgrowing them, eliminating them, leaving you with this pattern in transition, but here completely gone, perhaps, of this scaffolding around the fatty tissue. So that pattern of infiltration is very helpful. This tumor is fairly low grade. You can see that it's the nuclei are not highly pleomorphic, and the tumor cells do not have any high degree of mitotic rate or anaplasia as we look at it. So those key features, infiltration around adnexal structures, infiltration in and around subcutaneous fat, dermal location, are all helpful to begin to define a dermal spindle cell neoplasm where the differential would include a dermatofibroma, which would be benign, or a dermatofibrosarcoma protuberans, which would be the low-grade malignant lesion. Now, they do have considerable overlap, but they will have differential expression of CD34. And if you come to the next stage of being able to do the translocation testing by FISH, these have a COL1A1 PDGFB translocation, which is considered diagnostic and confirmatory of the potential malignant behavior of these lesions. Now, they don't have a high metastatic rate. They generally are controlled with complete excision, but you don't want to mistake them for a dermatofibroma and leave it to grow and become bulky and potentially problematic on the local level. I think I have one more slide of this here in the deck to show you, just to let you see another example of this or another view of this, and to contrast this in this situation with the post-biopsy changes, which are here central. You can see here is where the biopsy has come from. And then on the periphery, we see this lesion growing amidst the dermis, infiltrating into the subcutaneous fat. Now, in general, there will be something of a little bit of a grund zone between the epidermis and this tumor, but that may be a little bit obscured. And you may get some degree of epidermal reaction, as you see here, over the surface of this tumor. Notably, dermatofibromas are remarkable for this change of an epidermal hyperplasia, and even on occasion can develop little basal cell carcinomas in this overlying epidermis that can be a cause for mistaken identity of these tumors. So a nice example of Dermatofibrosarcoma protuberans. This was a case occurring in the vulva, not a very common location, but hence it's crossing my desk because it was managed by a GYN oncologist. Okay, well, let's come back to the deep retroperitoneum and talk about well-differentiated liposarcoma. And the reason that's of importance is to be able to understand dedifferentiation. Because as an entity, well-differentiated liposarcoma is not life-threatening. But when it develops a higher grade tumor or solid tumor, it becomes more of a threat. So typically, well-differentiated liposarcoma in the retroperitoneum has some peripheral areas where you have well-defined fatty tissue, or in this case, not so well-defined fatty tissue, but a more low-grade appearing lesion. This is slightly spindled here in the subperitoneal areas. As you can see, here's the peritoneal surface, and here's this tumor with a very low-grade spindle cell appearance. There's not much normal fat remaining here. There are a few slightly atypical cells in the midst of this. So, if we were looking at just this and we had some normal fatty tissue next door, this degree of atypia would probably get us to say, oh, could this be a well-differentiated liposarcoma? Well, that in fact is what we had next door, but what do we do with this area that's more solid? It still has some branching vessels, some sort of fatty appearance, but it's lost any indication of there being fatty stroma in the tumor cells. What do we do with this sort of appearance of a sort of a low-grade, more solid appearing lesion? Well, of late, we've begun to recognize that in addition to the high-grade pleomorphic dedifferentiation, there also are occasions where you can get low-grade dedifferentiation out of a well-differentiated liposarcoma. And probably these have different molecular drivers, as it would make sense. The molecules in the nucleus are what drive the morphology. But they do still retain the MDM2 mutation that is characteristic of well-differentiated liposarcoma / atypical lipomatous tumor and dedifferentiated liposarcoma. So I present this case as an opportunity to reflect and recognize that atypical lipomatous tumor, well-differentiated liposarcoma, can follow a dedifferentiation pathway that is relatively low grade, at least in terms of morphology. Not a lot is known about their recurrence risk, but it seems to be lower. The other thing that's important to note is that with this pattern of low-grade dedifferentiation can also occasionally follow a heterologous elements type of pattern with some smooth muscle, potentially even other tissues like cartilage and bone on occasion. So be liberal in your criteria for looking for MDM2 mutations, particularly in that retroperitoneal location. Now here's an example of the MDM2 immunohistochemistry, not from this case, but another example, I think, to just illustrate one of the challenges with MDM2 immunohistochemistry, like that of beta-catenin, is that interpretation and sensitivity can be a little bit problematic. Here we can see there are a number of brown cells here, and it does appear that some of the nuclei are staining positively. So I think I would interpret this as being a positive MDM2 stain. But because of the challenge with interpretation and variability in the staining sensitivity, we have moved towards relying on MDM FISH testing rather than the immunohistochemistry alone in these cases. It's also important to recognize that in certain situations, MDM2 immunohistochemistry positivity, nuclear staining, is not entirely specific for liposarcoma. And so what are some of the tumors where MDM2 staining can occur? Well, parosteal osteosarcoma is one. Now that's usually a bone-forming tumor, a low-grade bone-forming tumor with a spindle cell component. But if you just have a biopsy, you miss the bone piece of it, you could mistake that. Malignant peripheral nerve sheath tumors can also have MDM2 staining. And that's also a tumor in some situations where you might raise that concern. Now, obviously with MPNST, you should not have an adjacent well-differentiated liposarcoma, and most of them are not retroperitoneal in location, but bearing in mind that nerves run through there, patients with neurofibromatosis can have retroperitoneal tumors. Yeah, you need to be aware of that issue. And in addition, in the endometrium, endometrial stromal sarcomas, some rhabdomyosarcomas, and some desmoid tumors can express MDM2. So bearing in mind those possible confounding issues, interpret your MDM2 stain cautiously. Okay, well, we'll finish up here with one additional sarcoma without a particular pairing, but with some of the same caveats. Looking at this tumor, we notice how nested it is. And so oftentimes we think nested tumor, epithelial type morphology. This is fairly blue. It's got this nested pattern, a little bit of clearing, falling apart sort of appearance, fairly uniform cells here. This is a tumor where, as we look at higher magnification, we see, a lot of clear cytoplasm, a little bit of maybe cytoplasmic borders here between these cells, around these cells, relatively dark staining nuclei, and we might wonder about various epithelial neoplasms, maybe even renal cell carcinomas, other clear cell tumors as possibilities. However, there's another little clue here as we look around, and I think you can begin to see it here. We have some pigment here, pigmented cells. And so is this just from hemorrhage, or could this be melanin? And in fact, in this particular situation, this is an example of a clear cell sarcoma, which, as you all know, has some melanocytic features, and therefore can be confused or overlapped with various other melanocytic tumors. Now, this doesn't have the typical morphology of metastatic melanoma. It's obviously a small round blue cell type of sarcoma, but with the adjunct or associated presence of melanocytic evidence here, you would begin to wonder about a clear cell sarcoma. This tumor has been termed melanoma of soft parts because of this melanocytic feature, but it tends to occur in the tendons, the aponeuroses around the knee and other locations. It tends to be patients who are in their early adulthood stage of life. And in terms of the specifics here, there are a number of possible translocations that can be assigned with this tumor, generally involving the EWSR marker, so T1222 or T222, where it pairs with ATF1 or CREB1, are also possibilities in this particular tumor. So again, fairly well differentiated, uniform, monotonous tumor. Best be looking for translocations like synovial sarcoma, like the low-grade fibromyxoid sarcoma, like dermatofibrosarcoma, and so forth. These are the tumors where you want to be thinking about translocations. Well, I appreciate you joining me today for this review through a number of soft tissue lesions. I appreciated the questions that we've had come through in the chat box and that we were able to talk about. I hope that you'll post any further questions in the comments section, and we can continue the discussion. And I look forward to being with you again in December, where we will have a pre-Christmas sign out session with the professor. So until next time, thanks so much for joining me, and I look forward to being with you again.